Why, when the ladies had their session yesterday, there were cookies and cake out there, and when you have a heart session, you get veggies and fruits. And no smoking. That was terrific. It was to the point. Really, you all think it's easy not to follow the rules, but you have to do that. It'll extend your life and your happy days a lot. A little comment about this Dr. Seth Goldberg. Again, you can read about him in the programs. It says symptoms, treatment, and when to worry. When to worry is when your doctor, your primary care physician says, you got to go see Dr. Goldberg right away. That has happened in my office, not quite that way. But the reality is we all have hearts that go pitter-patter at times. And I have one patient I've been following for over 40 years who has skipped heartbeats, which are totally innocent. You have to know when they mean something, when they don't. If you have any questions, ask your physician. And if he worries, he'll send you to Dr. Goldberg. No further introduction. Again, any questions?
Distinct self.
Connie has a pad.
Okay, thank you, Dr. Bright.
The self thing, we're good.
Like I said, I'm Seth Goldberg. I did my internal medicine training in Boston, and then my wife convinced me to move to New York, so I finished my training at Sinai, and I've been here for about 10 years. Not a Yankees fan, sorry to disappoint, but no questions about any baseball teams.
Or football teams.
Or football teams, fair enough. So Dr. Pantone kind of focused on coronary disease, the sort of plumbing of the heart. Electricians are also needed for the heart. So I'm going to focus on the electrical system of the heart, which is often sort of, it's kind of like the little kid brother in terms of heart problems and disease. So hopefully I'll shed some light on some of the problems that can arise. So let me start by explaining the sort of normal physiology of the heart's electrical system. All our hearts are currently beating, fortunately, and they are driven by some cells in the heart in the sinus node in the upper right chamber of the heart. So these cells tell the heart when to beat. When we're resting, our hearts should be beating 60 to 100 times a minute. When we exercise, that rate increases to increase cardiac output and pumping. When we're sleeping and resting, the heart relaxes and that rate goes down, sometimes into the 40s even. That's all normal. The sinus node then sends signals through the upper chamber to the sort of toll booth in the heart, the AV node. Okay? This allows signals to pass down to the ventricles, which are the main pumping chambers of the heart, which do really most of the work of the heart. They basically both receive and then allow impulses to pass down. If the upper chamber were to go into a fast rhythm, this kind of toll booth can prevent some of those impulses from getting down and prevent your heart from racing very fast and trying to pump very quickly. If this AV node becomes diseased and fails to pass enough impulses down, that's when the heart can become very slow, and one might develop symptoms of slow heart rhythms. If there's a complete blockage of electrical impulses at that point, the lower chamber does usually beat on its own in a very slow way. If that happens, patients often end up needing a pacemaker. So I wanted to kind of focus on the types of symptoms that anyone might experience and kind of keep this centered toward what an individual might be concerned about regarding symptoms and what they might represent. So abnormal heart rhythms can be either slow or fast. We're going to focus on the fast ones. The slow ones tend to occur as people get older, and can lead to a need for a pacemaker if patients have symptoms from slow heartbeats in general. Most abnormal heart rhythms are from the upper chamber. Okay, and there's a variety of different types. We'll kind of talk about them. Occasionally, they can also come from the lower chamber, and those tend to be more concerning in general, but are also less common. Many times they will lead to symptoms, but in certain cases, some of these rhythm disorders may be asymptomatic. And you might go to your doctor's office and they perform an EKG and they say, oh, you have an abnormal heart rhythm. You may be very surprised to hear that. And it may end up being something you don't need to worry about, but it may require further investigation. So what are some of the symptoms that people can experience with abnormal heart rhythms? The most common is palpitations, and probably 50% of the patients that come to see me, this is their complaint. Palpitations are really the sensation of your heart beating. It doesn't mean that there's an abnormality. Very often when people are lying down in bed at night, it's dark, it's quiet, the head is at the same level as the heart, so blood flow is kind of heading right towards the head. People can have the sensation of feeling their heart beating. That's completely normal. On the other hand, when the heart goes into an abnormal rhythm that may be fast or irregular, people may feel the sensation of a fish flopping in their chest, or drums beating strangely, or very, very rapid heartbeats. So all these are palpitations. Some people come to me with this symptom and we have to investigate what might be the cause. Other things that are not uncommon, especially with more rapid heart rhythms, are shortness of breath with exertion, particularly dizziness. Sometimes these rapid heartbeats actually decrease the amount of blood that the heart is able to pump, so it can lead to dizziness. Just generalized weakness, chest discomfort, because they do increase the demand on the heart, just like aggressive exercise. Some people do complain of chest pains. And finally, even fainting can be associated with some fast heart rhythms, especially more dangerous ones. When someone comes to the office and I take a history, these are the types of things I want to know about the rhythm. So when it happens, how long does it last? Is it a second when you feel a skipped heartbeat, or is it 3 hours of the heart racing in the chest? Triggers are often associated with certain abnormal heart rhythms. These can include excess caffeine use. Overindulging in a big fatty meal can trigger abnormal heart rhythms. Alcohol use, not getting enough sleep. All these things can trigger certain heart dysrhythmias. So it's not uncommon for something called holiday heart. People, holiday weekend, they overindulge, and they find themselves, they wake up one morning, their heart's kind of going crazy, and they rush to the emergency room. So sometimes certain arrhythmias do have triggers that can be preventable. Associated symptoms, we kind of mentioned some of them beyond palpitations, so we're always careful to determine if there are other symptoms. Sometimes an arrhythmia will suggest that there may be another underlying heart problem, like coronary artery disease, that we might be able to pick up. And then, how does this stop? Is there something that the patient can do to stop it? Some people say, I cough and my fast heartbeat stops, or I bend over and it just seems to stop on its own. So these can be clues as to what might be happening when I talk to patients. So what you don't want to do is go to a doctor that's going to basically do every test in the book when they hear you have a symptom. So this says, your patient had palpitations for 2 minutes in 1989. Let's get an EKG, stress test, echo, chest CT, cardiac cath, and place a pacemaker at shift change. So we take a more stepwise approach to trying to figure out what's going on. I just saw a young woman in the office today who's in her 30s, and she complained of palpitations lasting about 10 minutes that were very intense and started very suddenly, but they only happen every 2 months. So her EKG was normal, and I could put on a short monitor for a day, but the likelihood of catching anything would be very low. So we moved to something where there's more long-term monitoring in the hopes of catching it. So we try to figure out the best test for the given patient. So when patients do come to my office with these symptoms, the first thing to do again is a careful history that can be very helpful. Every patient will get an EKG. These may show me that the patient's in an arrhythmia at the very time they're seeing me. They may suggest that the patient has an extra electrical connection in the heart that would predispose them to a particular abnormal heart rhythm. Or oftentimes the EKG is normal, and then we've got to do more investigation. So for patients with reasonably frequent symptoms, we'll often start with a Holter monitor, as shown here. This is a small box about the size of a mobile phone. It straps on the belt. A couple of wires are attached to the chest, and it monitors the heart rhythm continuously for 24 hours. So not only will it pick up an abnormal rhythm during that time, if a patient has a symptom, they can connect that moment in time with whatever was happening on the Holter monitor. It also quantifies or measures the exact number of heartbeats and the type of heartbeat each one is. So I will get a report that says someone had 100,000 heartbeats. There were 20,000 extra beats from the lower chamber and 30 from the upper chamber. And that will help me to determine what the problem might be. Depending on the patient's symptoms and history, we may get an echocardiogram. Dr. Ponton mentioned that's an ultrasound to look at the structure of the heart. And then, like the patient I mentioned, sometimes we need to put on a longer-term event monitor. Often the next step is a 30-day monitor, which is really most important for patients who have occasional symptoms. They wear this monitor, it's kind of exhausting and annoying, and then 2 weeks later they have palpitations for 10 minutes and they press the button and we catch whatever they're feeling. So it's very helpful to correlate symptoms with a potential abnormal rhythm. So there are many types of fast heartbeats, and I'm going to keep this sort of broad, but in general there's several types that come from the upper chamber. These are the more common types of abnormal rhythm. And the general category is supraventricular tachycardia, so from above the ventricle and fast heartbeat. SVT is what we call it in electrophysiology. These types of rhythms can affect all ages, from fetuses in utero to the very elderly. And they're either due to a group of overactive cells in the upper chamber that's different from the normal sinus node, or due to an extra electrical connection between the upper and lower chambers that can lead to a sort of short circuit of the heart. This is an electrical extra connection that people are born with, oftentimes is not a problem for decades, and then at some point in life starts to lead to these types of abnormal rhythms. The good thing about SVT, and what makes most patients I see very relieved, is that most of these things are not dangerous. They do not lead to heart attack, they do not cause your heart to stop, and thus treatment is aimed at symptomatic improvement and is really guided by the patient's desire to about what type of treatments they want and how much their symptoms bother them. Like I mentioned, some of these have triggers, others are just sporadic and start out of the blue with no particular warning. They can last minutes to hours, sometimes longer. And the treatment is variable, but usually the first thing that we start with is medication. Depending on the frequency of the symptoms, this can be a daily medication the patient takes all the time to help prevent or reduce the symptoms of the abnormal rhythm. Or in patients that have occasional symptoms, we can use what's called a pill in the pocket, where a patient just takes the pill when they get the symptoms, and hopefully the medication helps to stop the episode that's occurring. In some patients, they're either very, very symptomatic, or they try medication and it doesn't work for them. We do have alternative invasive treatments which can usually offer a cure for this type of problem. And this is sort of what I specialize in and I enjoy doing most. So we can do an electrophysiology study, or EP study. It is a type of catheterization, but generally speaking, we go in through the vein instead of the artery. It's done in the cath lab, and what we do when we put several wires into the heart, and we test the whole electrical system, and then induce or try to induce these fast heartbeats to determine what is the critical cause, either that extra connection or those extra group of cells. We can then go in and heat up the tip of one of our wires and get rid of either that connection or those cells almost all the time. So this can cure most types of SVT. That's not me, but so there's a sort of another category of abnormal rhythms from the upper chamber, and this is the most common type of abnormal heart rhythm, called atrial fibrillation. I'm sure some of you have heard of this. It actually affects 1% of the population of the United States, so it's extremely common, and it becomes more common as we get older. It is also more common in patients with other forms of heart disease, hypertension, coronary disease. So it's something that I see every day. The rhythm is a little less well understood than the other types of supraventricular tachycardia, which usually have discrete causes. Atrial fibrillation is a very chaotic rhythm occurring in the upper chamber of the heart. We know what seems to trigger it most of the time, but we don't really understand well what perpetuates it, and that's why that slide is there, because it just looks like a whole bunch of gobbledygook. There's a lot of basic science examining what the causes are, but because we don't understand it really, really well, the treatments are not as effective as they are for supraventricular tachycardias. Atrial fibrillation is a very irregular rhythm, so this leads to irregular, often fast heartbeats in the lower chamber. So similar symptoms, but more of that drums beating in the chest, fish flopping around type of symptom is typical. I kind of mentioned holiday heart. Atrial fibrillation can stop spontaneously, come and go, or once it kicks in, the heart may just stay in it until something is done to stop it. Again, most of the symptoms of this rhythm are also more aggravating than dangerous. So it's rare that this rhythm is an emergency and requires an urgent visit to the emergency room. That certainly is common practice among many doctors because it's hard to know what to do right away, and often the heart rate is very fast. So many patients do get referred to the emergency room, and that is certainly an appropriate thing to do. So again, treatment of atrial fibrillation is mainly based on symptom relief with medications or other approaches, which we'll discuss. But the other side of atrial fibrillation is that there is an increased risk of stroke with this arrhythmia. So this is something we need to take seriously. The reason is that the upper chamber of the heart, instead of beating regularly and contracting normally, is kind of quivering. So there's stasis of blood in that upper chamber, which can lead to clot formation and the possibility of a stroke. We know that there are different risk factors that increase a given person's chance of having a stroke if they have AFib. So we can kind of give a person a percentage annually of what their risk might be with this rhythm. Based on that percentage, we often decide that blood thinners are something a patient might benefit from. But the benefit of blood thinning and preventing stroke has to outweigh the increased risk of bleeding, which might occur with a blood thinner. Traditionally, we used warfarin or Coumadin, which people might have heard of. It's been around for a long time. Downsides of Coumadin are the levels kind of go up and down, requires frequent blood checks, interferes with certain foods and medications, and is really just a pain. And is not very reliable. In the past couple of years, several new blood thinners have come to market, which in large studies seem to be are as good or better than Coumadin. So these are being prescribed more and more. and they're much easier for patients to take if they need them. So again, the main goal of treating AFib is for symptom relief. We also know that long-term atrial fibrillation can cause called sort of remodeling of the heart, both the upper and the lower chamber. So as people are in AFib for longer amounts of time, it becomes more difficult to restore the normal heart rhythm. Medications are aimed at either just slowing down the heart when we think someone's chance of getting back to normal rhythm is low, or other medications are meant to maintain normal rhythm and prevent the AFib from coming back once a patient is back in normal rhythm. Even with these medications, recurrence is common, unfortunately. So for patients in whom medication doesn't work, we can try other things. Cardioversion is a sort of a quick fix to someone who's in atrial fibrillation all the time. It involves basically an external electrical shock that's delivered to the heart that stops the AFib and allows the normal rhythm to take over. It sounds terrifying, and you see it on television, and in a controlled setting it's extremely safe and effective for making symptomatic patients feel better. But even then, it doesn't change the underlying substrate of the heart. The underlying chance of having AFib remains. So in certain patients who we feel have a good likelihood of success, we can offer ablation similar to other types of fast heartbeats from the upper chamber. This is a little bit more of a complicated procedure. It's done under general anesthesia as opposed to mild sedation, and takes several hours. And basically we go in and identify the triggers for the AFib and try to electrically separate them from the heart. Picture, is that the picture? Yeah. So this is a case I did last week. We use complicated tools to help us make a three-dimensional map of an individual's left atrium, left upper chamber, which you see here. There's 4 veins that flow in. You can see these 4 veins. And this is where the triggers for AFib generally come from in about 95% of patients. These red dots are areas that we've ablated or caused heat-related damage, and then will form scar, which then blocks those trigger beats from entering the chamber and triggering the AFib. So depending on the type of AFib that a patient might have, this procedure can rid patients of symptoms between 60 and 85% of the time. So we kind of go through a given patient's likelihood of success when they're entertaining having this procedure done. Finally, I'll just touch on rhythms from the lower chamber of the heart. In general, these can be dangerous rhythms. They almost always affect patients who have other types of heart disease. So patients who have weak heart muscles because they've suffered heart attacks, who have scarring in the heart for other reasons, may be at risk for these types of heart rhythm problems. When the lower chamber goes into a very rapid rhythm, the heart often cannot effectively pump any blood, and patients can die. So we want to screen patients who may be at risk for these and potentially protect them from this type of heart rhythm problem. If someone were to suffer this problem, not in the hospital, some patients do die of this problem. Other patients suffer fainting. So occasionally people will just feel palpitations or shortness of breath. But most of this rhythm is based on screening patients who are at risk. So usually an internist or cardiologist will send me a patient because they're worried that they might get this down the road. And the protective device we have for this type of problem is called a defibrillator. It's a pacemaker as well as a defibrillator. A defibrillator is a device that goes under the skin, monitors the patient for malignant arrhythmias all the time, and if it sees one, it can treat the condition and potentially save the patient's life. We also have other medications if someone is suffering from this type of arrhythmia frequently that can help to suppress it. Generally, this type of patient is quite sick and requires, you know, a lot of frequent treatment. So just to sum up, before we take questions, the bottom line is that palpitations may be caused by abnormal heart rhythms, or they may be just the sensation of the normal heartbeats. In general, these tend not to be an emergency, but should be looked into because sometimes other things like the risk of stroke may come out that's important. Once this specific problem is identified, then we have numerous treatment options from medications to invasive treatments, all aimed at really making patients feel better. And many causes are actually curable. I think that's all. Thank you.